Alan to take it away for us.
I will, David. And will you send me a link to the YouTube channel when it's done? Is that
Yes, I'll do that. Yeah.
okay? I like to put it on my website. Well, very nice to meet all of you. I reviewed the book again last night, and I must say I felt highly intimidated. Like there's no way I'm going to be able to meet up to the expectations of your prior presenters. So I want to lower all of your expectations. And I speak a bit with my tail between my legs. But let me begin with an overview. I'm going to talk for about an hour. So I'll make a note. I always end up going over, but I think I reduced my outline enough to make it an hour. I'm going to begin by introducing me and the nature of my work, how what I do for a living relates to the central concern of this book, which is the mind-body problem. I'm going to describe the nuances of a long-term practice of psychoanalytic psychotherapy or psychoanalysis. I have 2 case presentations, 3, and I have another one if I have enough time left, which I probably won't. The case presentations are intended to exemplify the psychophysiology of doing psychoanalytic psychotherapy and why it relates to John's interest in the mind-body problem. Toward the very end, I'm going to do a little bit of shameless self-promotion regarding a newsletter I write and a book I have coming out, and then I will wrap up the presentation. Okay, so here we go, starting with what I do. So I've basically been in private practice for 44 years. That's a bit of an exaggeration because I count my very first internship, which was in 1979. And I used to do that to show off, but now I realize that it's such a long time, it has this negative effect of making me sound old. So I'm probably going to start trimming that back because I wasn't licensed until 1988. So I do half individual psychotherapy, half couples therapy. I also used to have a very active practice in forensic psychology. And I'm board certified in that area, which is a pretty broad area, but I did, and I still do, administrative law. I used to do administrative law and employment law. Administrative law in the US is anything involving a licensed professional. So it could be lawyers, doctors, chiropractors who were having severe psychological problems, or a lot of it is mental health professionals, psychologists. I do not have a cold, it's cold out here, so I have a little runny nose. Who have done something unethical or illegal in their practice. That's the only thing that I still do. I'm working on a case right now of a psychologist who was told about, she had reasonable suspicion to suspect child abuse. Interestingly, it's in her own clinical notes, but she never made a child abuse report, which in the state of California is actually a misdemeanor. And I also used to do employment law, which is like sexual harassment, wrongful termination, racial discrimination. Those are very interesting to me. And they didn't take much of a toll on the mind body, but they did take some when I would be evaluating someone who I knew was going to lose their license after I evaluated them. That was a painful experience. Or in the cases of some of these wrongful termination cases or sexual harassment, if there just wasn't really enough symptomatology in the person to warrant them getting an award, it would make me feel bad, but nothing like happens in the practice of depth psychotherapy. I've been doing scholarly work for around 10 years. I consider myself the union organizer of psychoanalysis because one of my main interests is in bringing all the warring tribes together, Jungians, Kleinians, Freudians, relational psychoanalysts, in my view and many other people's views, really practice much more similarly than others. I had a paper published in 2022 in the International Journal called Chasing Infinity, in which I propose a model that brings everyone under the same tent. I've also been interested in how kind of the unique, inimicable nature of psychoanalytic dyads. And early on, I wrote a couple of papers about Kafka, what an interesting guy he is. Now, in terms of clinical work, as John told me, I was the only clinical paper, and these intimidating psychoanalytic and philosophical and neuropsychoanalytic papers about the mind-body problem approach it from an intellectual perspective. I was taking it from a very personal perspective. I'm a strong believer in non-dualism, although I also think it's nearly impossible for us to think about non-dualism because the very nature of language creates a duality, which I'm sure other presenters have spoken about it. Or as I use my children who are now in their 30s, but then when they were little kids, and I would talk about these ideas like how absurd it is for me to say, well, this is my hand. Well, no, this isn't my hand. This is also part of me. But even in as simple a thing as I'm using my hand to gesture during this presentation, I've already created a mind-body split. So I think it is all one, and I think we're all part of nature, but it's extremely difficult to talk about or understand because again, I'm repeating myself, but the act of talking about it is creating it. So that's about all I have to say about me. So let me transition now into psychoanalysis. And there's, well, first of all, let me present to you that it doesn't mean 4 times a week lying on a couch with someone smoking a cigar behind you, a white male usually furiously scribbling notes. In my view, and many people's views, could be once a week, every other week. And terms like psychodynamic, psychotherapy, psychoanalysis, depth psychotherapy are all synonymous. Some people would take issue with that, but I do not. And I've come up with 2 kind of metaphors. I know I presented at least one in the paper that you read, but in my 2022 paper, I suggest that all, and I'm just going to use different words as I go through it, all depth therapists create a professional frame for the transformational experience to occur. And that's everything from boundaries to time limits on sessions to the fact that you don't have coffee with your patients and so on. They bring an intense emotional presence to their patients, and that includes attunement, listening very carefully, respect, care, and so on. And then they engage their patients in various types of conscious and unconscious dialogue. Now that dialogue could be a 5-minute period of silence. It could be a confrontation, it could be an interpretation. But what is unique about the psychoanalytic project is you're trying to access unconscious material. But I propose that the unconscious exists on a continuum from secrets sort of on the most conscious end, secrets that people know, but they're barely able to even acknowledge to themselves, moving over to what there's sort of this interesting difference between disavowal and denial. Disavowal would be, yes, I'm drinking a bottle of scotch every night, but I don't really want to pay attention to that. and moving more toward the unconscious would be denial. I literally had a fellow who saw me 3 times, who then died 6 months later of alcoholism, referred by his internist because his liver enzymes were going crazy. And he told me, he was a classroom teacher, that he would drink 3 or 4 bottles of wine after he got home from school, but he never had more than 1 glass in his hand at a time. And this was not a psychotic person. It was really a pretty good example of denial. Um, and you can tell kind of why he didn't make it past the 3 sessions. So that's framing, presence, and engagement. And when we get to the shameless self-promotion, I have a book coming out in July called Lover, Exorcist, and Critic, Understanding Depth Psychotherapy. And I've also used those 3 analogies, and it really overlaps with framing, presence, and engagement, in that the lover obviously means no sexual contact, but the the kind of presence you want to bring to your patients is fairly close to the state of being in love, in that now it's asymmetrical, obviously, but you're attending to the person in a way that a lover would. And I'm very careful in the book to give all kinds of disclaimers, and I deliberately did it because it'll be provocative and I'll probably catch a lot of grief for it as well. The Exorcist, I took from, so anyway, basically the lover is the same as presence. The Exorcist analogy it comes from a well-known quote by Ronald Fairbairn, who actually talks about psychoanalysts as being the successors to exorcists. I think I have the wording fairly correct, because they are not only responsible for the confession of sins, but also for the casting out of devils. And when I give you one of my case examples, I will demonstrate what really severe, what Melanie Klein once called violent projective identification looks like. And part of any depth psychotherapy process, particularly with more primitively organized patients like borderline personality disorders, is that they project primitive mental content, thoughts, and emotions into the psychoanalyst, and you have to take possession of them, something Beyond talked a lot about, and process them in a way you can deliver back to them. So just an initial example, really kind of a pretty benign example, is think about your average passive aggressive person who turns in papers late or shows up late for sessions, or otherwise behaves in a passive aggressive way. They will cause people around them to feel angry at them. And when working with someone who's passive aggressive, you as the psychotherapist will begin to feel angry, and then your job is to find a way to kind of palatably reintroduce it to them without enraging them, causing them to feel hurt. That's why I think psychoanalytic psychotherapy is 80% art and 10% science and 10% unknown, because there's a lot of artistry to learning how to deliver that kind of information. But the exorcism parts, well, it's basically the lover and the exorcist are the most psychophysiologically taxing parts of doing depth psychotherapy, as will become evident in the case examples I present. The critic is really a subset of engagement, or I guess I'd say the exorcist and the critic are subsets of engagement, because when you're possessed by a patient's projections, you basically use interpretation and confrontation to deliver it back to the patient. One whole way to view psychoanalysis, and I get into this in the book, is much like a literary critic would analyze and critique a novel. You're looking at characterological patterns, just like you would look at the characterological patterns of protagonists and other characters in novels or plays or movies, and you're critiquing it. And it could be as simple as, I've noticed now that we've met for a year that you tend to become involved with very emotionally reactive women, or very kind of rejecting, abusing women or men. That's not very high on the level of the psychophysiological arousal of the psychoanalyst, but it's on the list. And that these are hard things to deliver to patients, again, with the artistry to cause enough upset to motivate them to change, but not enough upset that they go running out the door. A few other relevant preliminaries here. There's a huge continuum between traditional Freudian or Kleinian psychoanalysis on one end and intersubjective self-psychological relational psychoanalysis on the other end. The folks on this end, for example, think caring is actually part of the transformative process, that patients internalize your caring for them. The people on the more conservative end do not think that. They're kind of back to the original Platonic belief, Platonic as in Plato, that you need to strengthen the intellect so it has greater powers over the passions. In fact, I am more on the relational end. And I remember one of my Indian students telling me, well, I'm so surprised to hear that, because I was taught that my job is to understand my patients, not care for them. And that would be a really good example of the more traditional approaches. But what both ends of the continuum and everybody in between share is it is what Lewis Aaron calls an intimate but asymmetrical relationship. I had a training analysis with a very conservative ego psychologist. I still have some residual anger toward him because there was never the slightest bit of caring. I once called him in a time of crisis, one and only time, and he was terrible at responding to it. But even he would not deny it's a dyadic, intimate relationship. And that's very relevant to the psychophysiological toll that practicing depth therapy takes. Adam Phillips, who's a contemporary British psychoanalyst who to this day doesn't use email and still sends like typewritten manuscripts into publishers, who I'm sure they just have converted into digital files for him. I meant to get the actual quote for you, but I can capture the gist of it. He said, the bottom line is, and he's an object relational practitioner, so he's somewhere between these two extremes. He does a lot of interpreting of patients' internal worlds, is that, if the two people involved in psychoanalytic processes are not emotionally engaged and care for one another, nothing's really going to happen. And I'm a firm believer in that. So, you have the two parties ostensibly meeting for psychological change, but it's, in my strongly held view, it's always psychophysiological change. I have a kid brother who's now about to turn 60, who is a has a very successful pest control business, like spraying houses for bugs and stuff. One of my long held jokes is that we're in the same business. I just deal with pests in the unconscious mind, and he deals with pests in the real world. But many years ago, he's since been educated. He said, "Alan, I can't believe you get paid for what you do. You sit around and have conversations with people all day." And I do think a lot of people in the public think that way. Um, but it's far from the truth, as I'm sure you all know by now. And kind of a side idea about Michel Foucault wrote this fascinating book called The Birth of the Clinic. And any of you who read it would know that he talks about how, a few hundred years ago, of course, back then, a physician had a 50-50 chance of killing you as much as helping you. But physicians were much more aware of like who you were as a person. One of my 2 Kafka papers is about Kafka's short story, The Country Doctor. And it is that kind of relationship that he describes. But, more and more patients are relegated to the oncology floor, or the infectious disease department, and they get increasingly alienated from who they are as a person and more identified with whatever disease they have. And any of the psychoanalytic approaches are much more like The Country Doctor in that they are interested in the subjectivity of the person, not whether or not they have bipolar disorder or are in the middle of a major depression or are simply sad at the fact that their children in their late teenage and early 20s are beginning to leave the home. They want to know the whole story, and in that sense, they're much more like the Country Doctor. Okay, so unless there's a brief question right now, I'm ready to make a transition into my case examples. Any quick questions? No? Okay. Because they say humans can only pay attention for like 45 minutes at a time. And I'm already going to be pushing you at beyond the 15 minutes. So, all right. So this first fellow, he's actually in a paper that's just got accepted by the British Journal of Psychotherapy. This is a really good example of the price you pay for presence or being the lover, okay? Because this fellow is probably one of the most psychologically normal people I've ever had in my practice. I had a lot of interesting countertransference toward him because he was tall, dark, handsome, and more successful than me, and easily as intelligent than me, if not more so. So in other words, he was better than me in every single way. So that was an issue I had to work through. But dig this, okay? He saw me 3 weeks after he lifted his son, who had hung himself in his backyard, off of the chain and, spent the entire day while the police came. And he was in an extreme state of grief and guilt. Although I must say, and this goes back to kind of the normative levels of this fellow, his wife and the other children, the son had been in a state of schizophrenia for, I think, 3 or 4 years at that point, and they had gotten him the best care you could possibly get if one of your children, God forbid, turned out to be psychotic. Multiple psychiatric consultations, and when this young man was in the hospital, they would visit him twice a day. I don't know anybody I've never heard of any situation where, like in the morning visitation time and the evening visitation time, like the family support for this young man was unbelievable. But so I guess point number one, to have a fellow sitting there in my office. By the way, the tall, dark, and handsome stuff didn't really come out until later because he came in telling me this story in the first minute or two. I probably knew it on the phone. I'm sure I talked to him, usually touch base with someone on the phone before they come in. And that's really the point of my chapter, that when you're doing this work, and we're not even in the realm of demonic possessions yet, just to spend 45 minutes or 50 minutes in the presence of people that are in unbelievable pain just takes a toll. It can't not but elicit psychophysiological states of arousal. If I'm going to go into medicine now, I would say like heightened cortisol levels in me, flight and fight reactions being triggered in me, tremendous like mirror neurons firing in my mind that are mimicking his literal experience. It's a pretty interesting story because he did a really typical what if. I've seen this a number of times when there's a sudden death like this. Like he would at times spend the night in his son's room. So one of the what ifs was what if I would have spent the night in his room that night that he killed himself, which he didn't. Neither he or his wife did. There were signs he worried about missing, like the son had secretly gone to a hardware store that the family frequented and bought chains. The son had done a good job of planning for a lethal suicide, not a suicide attempt. And one of the things I found interesting about working with this guy I'll call Arthur was that it only took a few months to get through the what ifs. And a lot of that was me just normalizing that for him, that when you have an experience in the realm of the Lacanian real, are you guys familiar with the three registers that Lacan talked about, the symbolic, the imaginary, and the real? Looks like you are. There is no way to either talk about it or imagine it. And one of the ways people will typically try to fill in the gap in the real, the exposure to the real, is by trying to come up with some kind of a narrative. And he caught on to that pretty quickly. The other very interesting way, this happened in the first session, that he was really avoiding his own grief, was the entirety of the first session was taken up by his concern about his wife and his two daughters and how this was going to affect him. And I'd say one of the only interventions I had in that initial appointment, besides being very emotionally present with him, was really a combination of a confrontation / interpretation of that he was avoiding, that I said, you know, we have about 5 minutes left, Arthur, and I've heard nothing about your reaction. I've heard only about your worry about your wife, daughter one, daughter two. And that would be the confrontation, and the interpretation would be, I imagine that's a way that you unconsciously are avoiding, you know, facing into your own grief. And over the course of the next 6 or 7 months, he progressed through the grief pretty quickly. You know, when I was in graduate school in the 80s, they absurdly taught us that a grief reaction lasts about a year. Nobody believes that anymore. Most people like me think it's actually a lifetime process. The acute phase doesn't last, well, varies in length. But, you know, a smart, engaged guy that enjoyed his work, has good friends, um, close with family, a man of integrity and ethics. He really caught on to the nature of the what ifs pretty quickly. We did a lot of weeping together. Most of his weeping was done outside of my presence. Um, um, it was interesting to see the what ifs just kind of disappear, and he pretty quickly got into talking about his own pain. Uh, um, and then there were other kind of, I would call them good rationalizations, like not rationalization in the defensive sense, like understanding that in a sense his son had a terminal illness. His son used to talk about who he used to be and who he had become, like who he used to be between, childhood up to like age 17, and then who he was from age 17 till I think he was around 21 when he killed himself. And it was horrible. It was an unbelievable, horrible state of being. Um, and and even some reflections on Arthur's part about maybe this was a blessing in disguise. This guy would have had a life of unbelievable pain. By the way, in the 4 years with the schizophrenia, and because of the family's economic status and their just care and love, this guy had had multiple psychiatric consultations, had already been tried on a variety of antipsychotic medications. Unfortunately, none of them worked that well, and the young man also didn't like the way he felt on these meds. And then this is kind of a side point, but I guess it gives you another example of the psychophysiology of doing this kind of work. So I've had 2 bouts of endocarditis. Endocarditis is a bacterial infection of the heart. It's very rare unless you're a heroin addict. I joked with my various physicians that I really should have tried heroin because I would have liked to at least tried it. And now I know, I have the risk factor. But in my case, it was just it's like getting hit by a car or something. I must have bit into my cheek or flossed too hard or something like that, because a normal mouth bacteria got into my bloodstream. It only presented as back pain for about 2 months, but that's because, and 10 out of 10 physicians would have said I had strained my back. But the pain was actually caused by what's called discitis, which is when bacteria gets into intervertebral discs. And at the same time, it was eating away at my aortic valve, but I had no cardiac symptoms. I never did have cardiac symptoms. The back pain got so crippling, and then I got flu-like symptoms that my MD referred me to an infectious disease physician who said, well, this is the long shot, but let's do a blood culture. And then they found bacteria in my blood, and then I was immediately hospitalized because she was afraid of a vegetation going off the heart, which if that breaks off, you die immediately of a stroke or heart attack. I do think all my years of doing psychotherapy had lowered my immune response, although to my great shame and embarrassment, and people in the UK are often highly judgmental of this. I was 51, it was 2008. That week, the week that I was hospitalized, I did 53 clinical hours in a week. I'm, again, ashamed and embarrassed. No one should ever do that. I have a couple colleagues that still do that. I've never done it since. And by the way, the infectious disease doctor, who's basically a friend now, but completely denies that it could be any kind of, I could have done anything to lower my immune response. I just respectfully disagree with her, because there's no way that doing that much psychotherapy for so many years couldn't have compromised my immune system. Kind of a good argument for Darwin over God is that your arterial system is completely sterile but it's wrapped around your GI system, which is not sterile. Um, and you do get some bacteria in your blood every day, but your immune system knocks it out. But if you ever get too much, like putting a dirty needle into your vein, you're much prone to this disorder. But where I was going with that is the valve, which was replaced in 2008, had to be replaced again in 2018. And I thought that Arthur, we were really working towards termination after 2 years. And he was one of the people I was not going to have to tell about the upcoming surgery, because that's what the paper that was just accepted is about. It's called Cardiac Self-Disclosure, and it's about what happened with the patients I had to tell about my second procedure, because the first one was an emergency and I never got to tell anybody. I just vanished from my practice for 6 weeks. They got contacted by other people. So Arthur, we're in the termination process. And one of the issues we talked about over the course of the 2 years is that his wife had had an affair with a woman some years previously. And he had also had a pretty serious bout with prostate cancer. And we kind of worked through these two things, but it was really going to be one of my more successful terminations, I would say. And then trying to think if I had already, well, it doesn't really matter. In the few months before the 2018 open heart surgery, he learned that his wife was having the affair with the same woman again. So we descended into another course of psychotherapy having to do with that. But I'm going to end that case presentation on that note. And I'm quite certain you're all getting the point in that, particularly in those first 3 or 4 months, being with a guy in acute grief and in the tragic situation on so many levels, not only his grief, kind of the bad luck of having a son that has schizophrenia, hearing about the pain of the son, the kind of unbearable pain, enters your mind body. How can it not? The next guy is in the chapter, but I'll give you a lot more vividness this time. And I am going to finish this in an hour, I can already tell. So I'm going to call this guy Robert. Whenever I speak or write, I just do alphabetical order. So I went from Arthur to Bobby, but make it a little more formal. Such an interesting fellow. And now we definitely get into the exorcism idea and what happens when you're possessed by patients' projections. This guy was a physician. All this material is highly anonymized, by the way, so as to render it essentially fictional. Specialists in internal medicine contacted me because the Medical Board of California had disciplined him and required that he get psychotherapy, which already created a problem, which I will not have time to get into. He had huge staff turnover in that nurses and medical assistants and even people that did like billing for him would become infuriated with him and leave. So his practice was in disarray. And in addition to having narcissistic personality disorder, he had one of the worst cases of ADD I've ever seen. And this guy went through an Ivy League undergraduate and medical school. I don't understand how he could have possibly done both of those. I think he had such a strong achievement drive. And I know there was some money in his family. Either his mother had been a pretty well-known actress in the film business in the 1950s. Because I still don't understand how he could have coped with an internal medicine residency. But I know that he was put on probation several times during the residency process and had a lot of trouble, getting into the medical field. So that's the presenting problem. Um, he was able to choose his own the medical board said, you just get a name of someone and we'll tell you if it's okay. But again, a very intelligent guy, way into the superior end of intelligence, which also demonstrates how there's no correlation between intelligence and psychopathology. The only thing I got out of 1 year of studying statistics in graduate school is the word orthogonal, which means no correlation, no relationship at all. They're orthogonal to one another. So Robert got a few people he contacted said, you should see Alan Karbelnig, so he comes in, we start meeting, we work through his resentment pretty quickly about the whole forced nature of it. I typically try right away in those few instances I've seen someone that's on criminal probation or they're in domestic violence situations and psychotherapy is mandated by the courts. I'm sure you'd all agree that the first thing you want to do is try to get them interested in their own mind in some way, absorb their annoyance at the requirement. And sometimes you succeed at that and sometimes you don't. If you don't succeed, it turns out to be usually short-lived and not very interesting psychotherapy. If you do succeed, it can be very interesting. And in his case, it definitely was, because he did this stupendous idealization of me, which I immensely enjoyed, to the point of telling me I was the best psychologist in California, that he hoped that I really understood that. He used the phrase intellectual giant. I remember that one. I literally called my wife of now 40 years. This was about 5 or 6 years ago. I couldn't even wait till I got home. I called her from my cell phone and said, Amy, could I be an intellectual giant? I was, hoping so. And she quickly disabused me of that, which is very helpful. You need a lot of social support to do this work, by the way. You need to have hobbies, social support, and never see 53 patients in a week. Never, ever. And that period felt great, In my book, I don't talk about him, but I talk about a guy named Carlos, who is very similar, also narcissistic personality disorder. And the way I think of NPD, by the way, it's like an upgrade of borderline personality disorder. It's like a software upgrade. They're basically as fragmented and as involved in splitting and projective identification as borderlines do, but they have this grandiose self as a kind of a cohering element that people with borderline personality do not have. So, and using Cahushian terms, I would say he and I were in a twinship transference where I was the greatest, he was the greatest, and together we were the greatest. And you've all heard the statement, the higher the pedestal, the greater the fall. It's been too long for me to remember where my fall occurred. I like to think it was because I started to do some kind of serious confrontations of him. He did typical NPD, immense externalization of blame. It was always somebody else's fault. It was his staff this nurse was terrible, the clerk was incompetent, it was never about him. And as soon as he started to look at, his defensive structure would open enough to consider it was him, he quickly went on the attack against me. Nothing ever physical or in any way threatening, but in my 44 years, let's say 35 years, I don't think there's ever been more virulent attacks on me, including Alan, because I'm comfortable. I always introduce myself as Dr. Karbelnig. I'm sorry. I'll go, hey, Dr. Jones, nice to meet you. I'm Alan Karbelnig. Come on in on the first session. And so I invite them to call me by my first name. That's part of my relational approach. Sometimes they prefer to call me Dr. or Dr. Allen, and then I leave. I let them do that. But with him, of course, it was going to be Alan. There would be no question, but there would be Alan. I called him Bobby. Um, you are unbelievably incompetent. I can't even understand the degree of your incompetence. In fact, and a lot of times he'd say this while standing like in the doorway of my session of my consulting room. Because of the ADD, extremely difficult ending sessions with him. Well, the narcissism plus the ADD, I would almost have to shoo him out of the office, but he's like leaning against the, whatever you call that, the door sill, and with a pointing finger, you're so incompetent. I think you should delay your next appointment. You need to call a more experienced psychoanalyst and get help because you don't know what you're doing, Alan. You need help. The first couple times it hurt my feelings, particularly the drop from the idealization, which I thoroughly enjoyed. Luckily, I didn't call my wife on the way home and say, am I the worst psychologist in the state of California? I didn't want to hear the answer, basically. But quickly recovered, my intellect kicked in, if you will, and thought, well, this is what they do, you know? But let me tell you, it's a good example because since this is only 5 or 6 years ago, I don't care how many years of experience you have when you're sitting with someone whose wife just died a week ago, or who does this kind of projective identification, again, violent projective identification, it hurts. And you then recover. And I would say within a couple of months, it really didn't hurt at all because I saw it coming. And I began to interpret the waves. And typically, the people that are pretty low on the personality disorder spectrum have a kind of amnesia, because a common way you interpret it when you're the greatest is, remember, Bobby, a few weeks ago when you thought I was the worst, or when I'm the worst, remember a few weeks ago when you thought I was the greatest? And you're like integrating it into their consciousness. It's almost like a form of dissociative identity disorder. It's like on the way there, if you will. Let's see what else I have to say about him. Well, it got a lot better, but he was very difficult. He would not pay me on time. He would pay incomplete amounts of money. He would complain about the fee. Along the way, he lost his privileges in the major hospital near my office. And that was a whole other set of problems. He wanted me to go testify before the credentialing committee of this fairly major hospital that's near my office. And I told him I wasn't going to do that, that's just not my place to do that. And that brought up another piece of rage. And if we have time, when we get to the question and answer period, I could give you other case examples, but I hope that the example of the guy whose son, again, not only killed himself, but, he and one of his daughters had to lift this dead body up, deal with the police, and so on. It's a horror. And with Bobby, it's like, and I often say this when I'm teaching other groups about working with really any of the personality disorders, a lot of it is, it's like riding on a roller coaster, and your main job is just not to be thrown off. If you can just sort of keep in your seat and do framing, presence, engagement, or lover, exorcist, critic, it's going to be okay. But sometimes it's nearly impossible to not be thrown out of the seat. And I have been thrown out of the seat, or you have the patient that quits, or a combination of two. Sometimes I've been thrown out of the seat because I made an error that contributed to them uh, throwing me out. So I hope these situations clearly exemplify how clinical work can enter your mind body. I also had a very benign form of thyroid cancer in 2013. It's so benign they don't even stage it. But you know, your thyroid is where you get your motivation from. And I've always been kind of a hard-driven, motivated person who, that's why I did the 53 sessions and the forensic psychology and all that. And so basically I've had these 3 serious medical conditions since 2008. I feel totally fine. I actually get a little insulted when somebody who I haven't seen in a few years says, "Hey, how's your health?" It's like, what are you talking about? So I am in total disavowal and denial about it, by the way, although I have no restrictions. And the most recent valve they put in, knock on wood, can be replaced by the TAVR procedure, which stands for transarterial valve replacement, where they thread it up through your femoral artery and just put it into place in your heart. You don't have to have your chest, it's actually not cracked open, it's sawed open. By the way, if it's done well, you really get over it pretty quickly. My wife just had a hip replacement, which is 99% successful in the state of California. She's unfortunately in the 1%. The joint is working perfectly fine, but there's some muscular damage that's taking over a year for her to recover from. Like within about 6 weeks, I was pretty much back to normal after both procedures, but I highly recommend against it because like the week after it, you feel like you got hit by a truck and it ran over your body. You know, it is horrible. Okay, I'm working toward my conclusion here, which will be just a few minutes. Now, all professions share this risk of psychophysiological upset. Their patients can become angry with them. They can be sued for malpractice. But I would argue, and I know you're all going to agree with this, only psychoanalysts get involved in this kind of intimate yet asymmetrical relationship. They're also the only ones that are that vulnerable. Now that cardiac got accepted, I'm working on another really fun paper called The Psychoanalyst as Prostitute, where I make all these comparisons between what we do and what sex workers do. It includes the commodification of a relationship. But one of the things it includes is personal vulnerability. Like both occupations share personal vulnerability. And notice how in like lawyers have legal tomes behind them and all kinds of support staff. Physicians have white coats and stethoscopes and et cetera. My own internist once said to me, "I don't see how you can sit with a patient for 45 minutes. She goes, "When I get anxious or unhappy in any way, I say I have to go take a phone call, or I say I have to go check your records. I'll be right back." You know, we don't have that. We're in the room with the patient, personally vulnerable for all that period of time. And before I get to my closing, I'm doing 30 seconds of shameless self-promotion. For almost 3 years now, I've been writing a weekly newsletter called Journeys to the Unconscious Mind. I don't do it for the money. I do it to spread ideas. But this company that sponsors it, which is called Substack, they require me to charge a minimum $70 a year. If any of you just send me an email, I'll give you a year subscription happily. I would love to give you a year subscription. So please reach out if you want it. And then the book Lever Exorcist Critic is coming out next month through Phoenix Books, which recently merged with Carnet Books. Anyway, it's Phoenix Books, which is in the UK. And if you email me, I'll also send you a link to the book. So how do I conclude the presentation? I hope I provided you with a nice visceral example of the mind-body connection without getting into heavy-duty philosophy like all these fellows I'm in Oedipal competition with. And as I mentioned earlier, strong believer that it's just one. I'm in Vedanta philosophy, by the way. They talk about how Vedanta is a branch of the Hinduism, closely associated with Buddhism. They'll talk about how it's absurd that we describe ourselves as existing within these little like sacks of skin, when any of us could have our arms surgically amputated and we'd be perfectly fine. But you cut off the air, you're dead in 3 or 4 minutes. You cut off water, you're dead, I think, in 2 days, maybe 3 days. But how just sort of bizarre, and a good example of the imagination, that we see ourselves as contained within these sacks of skin when it's quite literally not true. And that is the end of my presentation. I only went 3 minutes over. So I'd love to take questions, comments, personal questions. One thing about having open heart surgery is you lose all your pride. I have no pride left. So bring it on.
Thanks, Alan. That's really great.
Glad you enjoyed it. And you cannot possibly ask a dumb question, by the way. Could ask me who's Sigmund Freud. Yeah.
That's not true, actually. But
Mhm.
I often think that practicing psychotherapy is detrimental to my intellect. It really, I often think, well, if I wasn't a therapist, you know, I'd probably have a much better academic career and I write more books and so on. But being a psychotherapist is so preoccupying and so tiring, that it doesn't, it distracts me from, you know, clear thinking, if you like.
That's interesting. I've not really thought about that because I often find it intellectually stimulating, but what you said is inarguable in the sense of just the time it takes and the preoccupation between appointments, particularly if you have a suicidal patient or an Arthur, or a Bobby, I mean, or an Arthur actually. Yeah, and I've been deliberately cutting back because I'm much more interested in writing now, and I have a bit of financial security. I found my sweet spot, by the way. It's 5 sessions a day. If I do 6, I'm tired. So anything up to 5 is kind of really a sweet spot, but that's so hard for beginning clinicians. They just don't have the luxury to do that. So it looks like you might have a question, Diane, or did I just misinterpret your body language?
Oh yeah, I do have a question. By the way, first of all, I'd like to thank you for the wonderful presentation. And I would like to ask you, knowing what you know now, what are the survival tips that you can give us?
Actually, I can't see who's talking. What's your name?
Dion.
Oh, it is Dion. Okay. I
Yeah.
think there's a delay. Okay.
Yeah.
I do know who's talking. Great question. Pretty easy to answer. I always have ideas for future papers in my mind. And one is that I have a lot of colleagues who, like the one woman I still know who sees, the week I had lunch with her 6 months ago, she had 52 clinical hours that week. I would like to write about how a lot of psychotherapists use their practice for their social needs because it is an easy way out. You're in the less vulnerable position. And it's also, I would suggest, a perversion because you should bring as few needs as possible to the relationship. That's why you come home so exhausted and kind of needy. So you want to avoid doing that. You want to limit the amount of hours that you do. It's very, very important, like this original idea of Freud talked about mental health is love and work. And then there were people after him that added that third area of play. So I would say, make sure you have an active recreational life, whatever that might be. For me, it's hiking, gardening. I have this way cool backyard that I basically created over like a 20-year period. Whatever it is for you, Dion, or any of you who are practicing. And then, boy, social support cannot be emphasized enough, and not just with colleagues. Although collegial social support is always really important. Like, I've never practiced alone. A lot of my colleagues practice alone. I've always been in offices where there's 3 or 4 consulting rooms. There's now some days, because people work at off hours, like the one I'm in now has 3 consulting rooms. I've been there for 8 years. It's in Old Town, Pasadena, which is a very kind of hip place, which is also great for your social life because there's cool restaurants and bars blocks away or half a block away. I think I would personally recommend against practicing alone, although a lot of people do that. When you have 2 or 3 colleagues, even though 3 or 4 days might go by, we don't even see each other, it's nice to hear their voices, or you get familiar with when people are done for the day, and you always have kind of someone to turn to. I also stayed in clinical supervision way beyond when I got psychoanalytic training. I paid privately for supervision until once you're licensed, they call it case consultation. I think that's another way to offset the loneliness and the pain. When my kids went to a private high school is when I stopped the clinical supervision because I couldn't afford both of us. I was in a study group for 25 years. Study groups are a good offset, but it's basically work and play, I'd say. I'm sorry, love, what a great Freudian slip, because I was a card-carrying workaholic for at least a quarter century. Love and work on having close friendships, romantic relationships. You really need a break. Funny story, totally relevant to your question, though. Part of I don't plan on ever stopping psychotherapy, but my current goal is to get down to 20 hours a week, and I'm pretty close now. But on Wednesdays, I have a home office now that it's kind of almost a private entrance. People walk down the side of the house, make a right, make another right, and it's like kind of a basement office. Wednesdays feel strange because at the end of the day, I walk up this back staircase that patients don't see, and I say, honey, I'm home. Like, there wasn't enough of a barrier. And when I'm working in Pasadena, it's only about a 15-minute drive, but even that drive creates this kind of cushion. Okay, now I'm in my home environment, and I'm curious. I know a number of people that all they do is work from home, how they create that space. I think if you do work at home, you need to find some way to create that space. Take a half-hour walk before you go into your house, something like that. But it's really loving relationships and a good recreational life are the way to prevent what happened to me, and do exercise, then do all the things you need to do for health. It's weird, in 2020, a good example of the unconscious, I became a vegan and I started going to the gym again, and I started meditating. None of those 3 things was related to anything cardiac. It just like emerged. It was like, well, it was 2 years after the second cardiac surgery. And I feel like now I lead a healthier lifestyle, in addition to having good love and good play. One thing I'm yearning for now, though, is I'm blessed by having 4 or 5 really close friendships, but none of them know each other. I'm kind of yearning for a community. So I may get involved in another group supervision or study group again, or a reading group, because I am missing the 3 people that are in my suite. We've had dinner together twice so far. That might be another source of community. I'm interested in doing more on climate change, maybe getting involved in a political organization, something that really changes the channel so that, let's say on a Saturday, you can completely escape from the situation you were in on maybe the Friday. Travel is also good, and not just to psychoanalytic conferences. Okay, so yeah.
Thank
So
you.
I have a obvious question. Sorry if I'm interrupting. Why do we do this? You mentioned need for intimacy. That's, I think, if we all recognize that and admit that, that's an important one. And Karen Marotta talks about that in her book, The Analyst's Vulnerability. And she actually an interview John Mills did with her about that. So that's quite interesting. And it's as if she's sort of bringing out of the closet our needs and why we do this without being too sheepish about it, like breaking that taboo. Why do we do this?
Is her last name Maruta with an M?
Yes.
Yeah, I'm gonna use that for my prostitute paper. Thank you. So why do we do this? Well, the ongoing joke is people do it because they have their own psychological problems and they think they're going to find a solution there. I would say that's one reason. Hopefully it's mostly a desire to help people. My grandfather and my father were physicians, and I began my undergraduate degree as a pre-med student. And then lucky for me, I took an introduction to philosophy course that same year, and that changed the course of my entire life. And I'd say it brought this sort of healing heritage into another venue. Because I do like the idea of helping people. I guess we could talk about mature and immature reasons. So imagine two categories. So mature reasons would be fascination with human subjectivity, interest in philosophy, literature, people, a desire to care and help, knowing you have a pretty good ability to tolerate pain. I've had a number of patients over the years, I could never do what you do. I would just be too upset. Immature reasons would be you think you're going to solve your own problems, which you do not. Or thinking, I think of one woman in particular, she's even said she doesn't really have any friends. And that's a real problem, that would be an immature reason. Oh, it was another immature reason. Super small percentage, but I've been involved with over 100 cases of psychologists having sex with patients. So a very small percentage of those are actually sexual predators who deliberately go into psychotherapy so they can prey on people. The vast majority of people that have sex with patients, by the way, are people that have gotten themselves in a vulnerable situation. One guy in my own area came down with Parkinson's disease, and then his marriage went really sour. And he had a sexual encounter with a woman that was later one of my analytic control cases. So I guess that's another reason. I think the fake intimacy might be a lot of it now that I think about it. Gee, I like to help people. I'm not so good with relationships, and now I can have a lot of them. But like I said, going back to my pest control brother, you're not having like fun conversations if you're doing a good job. Now, I get a good laugh once or twice every single day. It's not like it's never fun, but you really want to bring, this is not about my needs. And I violate this rule quite regularly. Like I'll have somebody in the film industry and I'll ask them a question that I'm interested in. How do they do this effect, But, ideally you're leaving all that out so that your emotional presence is all about who they are and what their needs are. So ironically, if you're going into therapy for that reason, you're either not going to be a very good therapist, or which I think about a third of the therapists out there, they're not very good therapists. Like, no offense to homemakers, but there's a lot of middle-aged homemakers that their kids grow up and they go to study to be psychotherapists. I happen to know some of them that are great psychotherapists, and some of them I think are not very good. But if you're doing the work good, well, like like David said when we started off the discussion part, you're beat at the end of the day. And at my sweet spot of 5, on occasion I'll do 6. I'm like wiped out. And then I think back when I was 51 and doing that many a week, I can't even imagine it. So I hope I answered your question, Susanna. Oh, you're on mute if you have a follow-up.
Yeah, just to add to that, thank you very much. Karen Maroda suggests also that we start in very early childhood, in a way, doing our practicums as in terms of early attachment style, who we are in the family, often middle children, the mediator. So in a way, we start our practice when we're children. That was one of her suggestions, which I really appreciated.
So interesting. Yeah. If I was in charge of the universe, this business would be taught through a old-fashioned apprenticeship where you would begin doing psychotherapy and you'd take classes along the way.
Yes.
Yeah. Okay. I thought, Margaret, did you have a question? No. Okay. Just playing with your pen.
I wrote something down.
Okay.
I have a silly theory that psychoanalytic psychotherapists are borderline and humanistic therapists are hysterics. Psychoanalytic therapists, they like the 50 minutes or 45 minutes you get just in it, and then you're out of it, right? The humanistic therapists, they like to have, do the cushions and drawings and this and that. And
I like it. As long as I'm exempted from the borderline category, but who knows?
Yeah, well, it's fun.
Yeah.
Alan, if nobody else has a question, may I ask another question?
Of course.
Yeah, I just would like to know, how do you put the boundaries in your analytical hour? Because as you just presented to us with those 2 cases, sometimes you really need to put the boundaries, and you need to do it in such a way that actually you don't reject your patients or clients. At the same time, you need to establish clear boundaries of what is allowed in the hour. How do you do that?
Great question. Like your other one. And it was Robert Stollerow, who is one of the co-founders of the intersubjective school, that said that we often fail to realize that every single day when we're doing our work, we basically say to people that are very attached to us, get the hell out. It's over. Get out. Like we're doing a rejection at the end of every session. So I'm going to give you the 3-minute answer when it really could be a 4-hour answer. And David, I really enjoy teaching. So if you ever want me to come back in some fashion, I would be really open to it. Not to mention a tax-deductible trip to the UK, which I would be particularly open to. There's a bunch of ways. There's a guy whose name actually is Bob, who I really dislike, and he will be in and out of my practice the rest of my life. Highly narcissistic, not really in the personality disorder thing way, but he would walk in and it would take him 5 minutes to kind of unpack his shit. He always had a briefcase, sometimes 2. He would take out like a notebook and this and that. And I'd say, our time is up. And it would take Bob 5 minutes to put his shit back in. So I confronted and interpreted this after we had a good rapport. And with him and people like that, this is not my general practice, but it is sort of my own little technical thing. I cannot be the only guy that have thought to this. People like that, I'll say, hey, I just want to give you a heads up. We have about 5 minutes left. Okay. I would certainly do that with Bobby, the guy that loved me or hated me. It was imperative. And with Bobby, I would stand up, like with maybe 30 seconds left. I would stand up and begin gesturing toward the door. And it had to be, if I did it with no time left, he'd still be there another 3 minutes. You know, I probably stood up like a minute. Sometimes it's psychoeducational, you know, just a brief sentence about, hey, part of how this works is we create a transformational space, and it needs to have a time limit on it, even though that can be painful to you, because it also invites you out parts of your unconscious mind, because you kind of know it's going to end. One of my favorite stories, man, I'm glad I have enough time to tell this, is a woman who, if you maybe you've heard the story, they call it the door handle statement. The patient tells you when they have their hand on the exit door. So this lovely woman, the first session is all about, she's about to retire from a Los Angeles law firm where she's been their librarian for like 30 years, which is a very significant job for a law firm, then turned into data management. And I like to kind of sum up at the end of an initial session, and it's a little off point, so I'm going to come back and answer more of your question. And I said, well, so it sounds like, Joni, you're kind of concerned about this vacuum you have before you. You've spent so much time devoted to your work, and so I think we'll be doing a lot of talking about like what's going to come next and how it's going with your family. And she's a woman married with several children, and literally her hand is on the door. And she says, I've also been having an affair with a woman at work for the last 10 years. So I suppose we should talk about that. And I said to her, oh, you saved the best for last. Yes, we'll talk about that next week. Interestingly, it turned out that her retirement was also going to mean the end of that relationship, because much to my envy, she was able to like travel around the world and send her husband and kids, look, here I am with Jill in Bali having a great time on this business trip. And if I were ever to have an affair, I would never have any ability to do anything like that. Anyway, side story. How else do you, with someone that's never been in therapy before, I do a little bit of psychoeducation. This is how it works. We have a regular time. I strive to end on time. I do not, like some television shows depict, and if someone's in the middle of a crying spell, I will go over by a minute or two. At the height of my career, I was working back-to-back sessions, which I also feel ashamed about. I do not do that anymore. I actually have 15-minute break between appointments. So it's nice to have a little bit of flexibility. On the other hand, I do not like to go more than 2 or 3 minutes over, because you don't want to get in the habit of it. There's also a lot of interesting phenomena that happen around when the time is up. Your more masochistic patients will often end the session for you. You watch them looking at the clock. There was one woman who would actually leave a minute early until we got into talking about it. And your more narcissistic patients, like the guy that brought all his work equipment and loaded it, would fill a whole couch, would always go over. So yeah, I'd say it's confrontation, interpretation of the behavior, and then pretty firm setting of limits. And then in extreme cases, and I think Robert is the only one that I can remember that I literally stood up. You have to do things like that, or else you're allowing yourself to be exploited, which is actually counter-therapeutic. I hope that fully answered your question, which was
Yeah.
another excellent one. It's
Yes.
a lot of supervision could be useful in that area. It's another quick side point here is you find a lot of insecurity among beginning therapists because unlike physicians or lawyers, there's nothing tangible that they're selling. So they'll feel guilty about, or often they'll feel like, well, I haven't given enough, And that's why I talk about this stuff with them, and I talk about the importance of charging a sufficiently high fee that you can make a living, because you are giving of your body and mind, I think, unlike any other profession except maybe prostitution. I got to add that to my paper. So that's why learning the technique and the art of boundaries is very important. And we won't have time to get into a bunch of other interesting stuff, like what if you're asked to have coffee? What if you run into a patient at a movie? I heard a story once where therapist is going to a movie on his own, patient going to a movie on his or her own. Patient comes up to him and says, "Hey, can we sit together?" How do you deal with those kinds of, those are all really nuanced situations. I've run into patients a ton. Pasadena is kind of a small town. Good thing I live in Glendale, which is 10 miles away. My colleagues that live in Pasadena run into them even more than I do. So I think maybe one brief question, or else we have to close up. But I want you to know I've really enjoyed this, and I sure hope it's been helpful to all of you. It's been a lot of fun.
How do we
What's
get?
your dog's name?
Yes.
I have two dogs, Zoe and Lucy. I'm going to end on a biological note. So Lucy is 9, and I would have bet $1,000. They're both Vizslas, which is a Hungarian pointing dog. They're hound kind of dogs. I would have bet $1,000 that Lucy would have been the dominant dog, because she's been here. She was here 7 years when Zoe came, and Zoe was age 10. Zoe immediately, that's the one barking right now, started whacking Lucy in the head, would kick Lucy off her bed places. Lucy would kind of wimp out. And now the younger one is the dominant. There's no question about it. But by the way, very important part of my support system. I love watching Netflix shows and movies, and my wife and I having those two like heated up adult teddy bears is just very curative. And, there's all this research on literally lowers blood pressure and stuff like that, having a dog. But I think there should be a law against having a puppy when you're over age 50, because it literally took us back into marriage counseling for the 3rd time. Because although my wife consented, she feels like it was a unfair arrangement, and that was short-lived, thankfully. So anyway, she's here to get the dog to stop bugging me, but we're out of time. Pleasure
Do we
meeting.
have
all.
your email? Is your email available so that we could access the suggestions of your
Yeah,
newsletter?
I'll give it to you, and it should also be on the string, but it's AM Karbelnig. So it's AM, and then my last name, which is KAR, B as in boy, EL, N as in Nancy, IG, G as in Gary, @gmail.com.
Thank you.
And you will not be bothering me. It might take me a while to get back to you, but again, I really welcome it. So thanks a lot, you guys. Have a great
Thank you.
week. Maybe we'll meet again. Thank you, David.
Yeah,
Okay.
Alan, take
Thank
care
you.
now.
Thanks
Okay,
so
take
much.
care.
All the best.
Okay.
Bye bye.
Okay, bye. Take care.
Bye-bye.
Bye.
Thank
Bye.
you.